Morning, afternoon, everyone. Tea time. So hopefully this will be fun for everyone to follow through, and hopefully the logic trail of what we're talking about in terms of transitions and stroke and what minor is. We're going to go through the definitions as we go along, just to give you an idea and context to the slides. Stop me if something is not making sense. I will try to walk through it quickly or slowly, depending on where the questions are, okay? It's nice to have this as an interactive session. Sometimes you can't hold your questions till then, which is perfectly fine. Right, so today we're talking about transitions of care after minor stroke. As you may know, I am at Columbia University. Some of the work that I'll be talking about today was funded through the internal KL2 grant. Some of it was funded through the institutional UL grant. I'm currently funded through the AHA Columbia University School of Medicine, and also through NIH, NINDS stroke on K23. So really today, we're going to talk about current state of affairs. What is transitions of care after stroke? What are stakeholder perspectives? How do we put them all together to think about tailored interventions? And what does behavior intervention design look like for this particular group of patients? So the lay of the land, just getting a sense of, in terms of stroke. Stroke used to be this one thing where you would die or live. It's no longer the case. So there is a decreased mortality from the fifth to the third leading, from the third to the fifth leading cause of death. Survivors are predicted to increase by 3.4 million in 2030, which means it's a 20% increase from 2012. We have an aging population, increasing stroke incidence amongst young adults. So more and more people are living with stroke. They are not dying. So what do we do with these people who are alive and along the spectrum of disability? So for those living with the stroke, there's unmet needs. So, and what are those needs? There's an increased incidence of recurrent stroke, which then leads to more disability. So it's a compounding problem. There's poor quality of life, right? Living with disability, and what does that really mean? And then recovery outcomes and needing to track those. So when we think about post-stroke care, what does that look like for somebody who has unmet needs and those needs are not quantified well enough? We have to think about, do they have a risk of having another stroke, which will then increase their unmet needs? Do they have poor quality of life? What do those outcomes look like long term? We know that this is important for secondary and tertiary stroke prevention. We also know that there is no current evidence-based comprehensive system in the US that is tailored well enough to provide the supports that these individuals need. Now, when we think about stroke recurrence, we know that risk factor control is tied to risk reduction, and that's your secondary prevention. What happens after a stroke to prevent you from having another stroke? You have to think about hypertension. We know reducing or improving hypertension control will improve the risk in terms of your recurrence. So just for example, 20% reduction will help those by reducing your blood pressure to like 10 millimeter mercury. So like I tell people at bedside, you improve your blood pressure control, your risk of having another stroke will go down by 20%. You improve your cholesterol, same thing. Diabetes, more than that. Smoking, same thing. But why is that relevant, and how together in conjunction they help you improve your overall control and risk of having another stroke? That's TBD. But if you look at all of these risk factors, the one that really jumps out at you is hypertension, because more than half of people that have had a stroke have uncontrolled blood pressure. And that is sort of a good initial target. Now, what does quality of life mean, and how are those outcomes that we have to think about? They're under-recognized because these are soft targets. It's not a reading. And what is that? What is physical disability? 75% of stroke survivors will have limb weakness, 30% will have language deficits. So I was able to speak perfectly yesterday, and today as a lecturer, I can speak a little bit better than I used to, maybe 2 days ago when I had the stroke, but I'm still not able to go back to work. That's impairing. That is disability. And how you view that disability to somebody else might just be, oh, this person stutters a little, but it's completely changed an individual's life because of what they were doing before. Same thing with cognitive impairment. 30% at 3 months. What does that even mean? Cognitive impairment. I can no longer function like I used to. Does that mean I can no longer play Candy Crush? Or does that mean I can no longer perform the neuropsychological assessments that I was trained for my whole life to do? So just contextualizing it to the individual. Psychological distress, 30% of people will have depression, anxiety, post-traumatic stress. Put that all together. If that is layered on top of existing depression, anxiety, post-traumatic stress, then that is only going to compound that person's problem. And how do we take care of that? Fatigue is normal, common, but up to 1 month. What are we doing after that? So that's all considered part of tertiary prevention or long-term. And so it's a public health problem because these are all individuals who are living with this on a daily basis. And so we have to think about how we define and monitor the problem. How are we individualizing based on each person's outcomes? And then what are the risks and the protective factors, developing and testing prevention strategies, assuming widespread adoption. And that all comes into defining and monitoring the problem, right? So that's the first thing. What is the problem? And then coming back to transitions of care. Well, what's the definition? It's the movement of a patient from one setting of care to another, which means I was in the ambulance. From the ambulance, they took me to the hospital. From the hospital, they put me upstairs in a bed. And then they sent me to a rehab institute. And then I got help at home in a rehabilitation facility of one different kind to another. It's a lot, right? Transitional care is when you think about the services and the environments that are engaged across these settings. So it's the actual setting itself. And then how do you interact interprofessionally to coordinate the kind of care that somebody needs across settings? This is something that nurses have essentially founded and thought about a lot more than we have. Then this is just a figure to put together to give you a sense of how difficult these transitions are for somebody who just had a stroke, cannot move one side, and is in the hospital. Maybe they go to the ICU. Maybe they then are stepped down to a different unit. Then they go to a floor unit. Then they go to a rehab. What type of rehab? Inpatient rehab versus skilled nursing. They go home with or without supports. And then they have to have all of these different services that need to come together to help them. That's difficult. It's a lot of moving pieces in a system that doesn't work and is therefore fragmented. So that's, what are the risk and protective factors here? We know that the bad things here are the high hospital 30-day and 90-day readmission rates that we are supposed to worry about. Poor discharge plans, like what's written on there, who's going to follow up, long length of stay, how long is the patient in the hospital, do they need to be there? And of course, that leads to low patient satisfaction. Things that are helpful is if you have engagement from the patient and the family, home-based care, early phone calls.
I was wondering how long it was going to take. I knew it was pretty close.
Yes, carry on.
It's a public health problem, right? So we have to think about strategies, widespread adoption, and then to layer that on top with racial and ethnic disparities. We know that Black, Hispanic, and American Indians have higher risk of stroke recurrence, poorly controlled risk factors. We know that they have worse neurological, cognitive, and functional outcomes. How are we putting that together in one system that supports equitably for those who need it? So, a framework, the framework of perhaps the socio-ecological model, where you think about the individual as part of a relationship, then as part of a community, and then as part of a society. And then breaking down at each level, what are perhaps the disparities that need to be addressed. So on the patient level, what are their preferences? Do they have mistrust? Is there discrimination? Is there a problem with adherence, health literacy? And the reason it's outlined here this way is to give you a sense of how many factors go in at each level to think about. So how we're thinking about this pervasively needs to distill down at least a few factors. So how do we go about doing that? Well, the NINDS just came up with this determinants of inequities in neurological disease, health and well-being framework. This was just I guess just a year ago. And this is based on that thought process of the socio-ecological framework, where if you look at the biological determinants, then how that factors in on an individual level, then the intermediate determinants, and then the social status, and then how that plays a role in the structural determinants. Why is that important? It's important because it plays a role in the continuum of care. So how somebody is getting pre-hospital care, and then in the acute hospital setting, early post-stroke care, and then the chronic phase, which is to give you an idea that a stroke is not a one-time event. Yes, it strikes you, but then it continues to strike you over time. And so understanding what the barriers and facilitators are at perhaps the most important stages is helpful for their long-term outcomes. And so there's multiple interventions that have studied stroke transitions, some more in the hospital, some in the clinical setting, some in the community setting, and then following them along. And you know, this is a heavy slide specifically for the reason that a lot has been done, but we still do not have comprehensive stroke systems that we know sustainably work for everyone. And it's been done internationally in different institutions, different sites. The MIST study I particularly like because we did see good outcomes in terms of physical health. I apologize for the small font here, but that's really what I wanted to point out is it's harder to quantify long-term outcomes in a population where adherence is an issue because they drop out at different points because the system's so fragmented. So then that brings me to the question of what are then the most common or most important things? Where's the low-hanging fruit that you can try to target? We know that blood pressure self-management is a big thing because more than half of stroke survivors have uncontrolled blood pressure. We know that perhaps physical activity can help with reducing the risk of stroke recurrence and then therefore keeping people from greater disability. We know that there is a gap between professional recommendations and real-world implementation, which is why there's a gap. Again, with minoritized patients, there's a wider gap because they're particularly vulnerable. Now, what's a mildly disabling stroke? That, you know, again, plays a role in why we're thinking about these modifiable risk factors specifically for this population. And again, talking about hypertension is the most modifiable risk factor. We know specifically that it remains poorly controlled in more than half. And they have, Black and Hispanic patients have limited access to care. So perhaps the care piece beyond the individual level is factoring in for them. And then, you know, the post-acute stroke care perhaps offers a valuable target. Why are we thinking about team-based care for these individuals? This is a graphic abstract that puts together all the interventions that are currently ongoing, thinking about pharmacist engagement in post-stroke interventions. And there's clearly quite a few, but has it made it to guideline yet? The answer is no. And that is because they're so variable, but they're also so under-recognized as being important to the value added when it comes to care management. And so with this article, which is currently submitted, we try to really understand what these patient-reported outcomes are and how they're quantified in these different studies that can perhaps help us understand what needs to happen for it to translate into public health policy. So just thinking about pharmacist engagement, we did a small proof of concept study where we engaged the pharmacists who spoke Spanish and were able to screen the patients for all of these post-stroke care outcomes. It was a small study, and we realized it was taking a lot of time to get all these people engaged and do the actual outcome measures or the patient-reported outcomes. But what we did find was all these patients came back for their next visit. Something stuck with them. So just thinking about understanding what the providers brought to our network, we did a survey. So this was a six-centered survey, and these are the results for our group where we had 24 stroke providers. Again, there were nurse practitioners, pharmacists, and had different race ethnicities. And we really asked them the same type of questions that we asked the patients. We had about 139 patients who responded to our questions, and we had good representation from the minority group, with 52% having public insurance, so about 50-50 split. The most interesting thing that came out of this was asking the providers, what are the biggest challenges that your patients face in their long-term care, and then asking the patients the same question. Interestingly enough, the top 3 responses were from both the patients and the providers. So it's not that they're not on the same page. The top 3 were managing chronic or debilitating effects of stroke, understanding the risk of stroke recurrence, and difficulty following lifestyle recommendations. Like, what are these recommendations? How do I follow them? And then interestingly enough, there's a higher percentage of people who are from minority groups who said they were worried about being unable to work or meet the expectations or responsibilities at home. So the burden counts. What do we know about where patients go after they have a stroke? Well, most of them go home. And that's what we found with our study as well. And then why minor stroke? Because these are people who are mildly disabled. So these are people who are still able to function almost at capacity, have a mild, perhaps, weakness in the hand, have mild difficulty speaking, but are good enough that when the physical therapist walks them, they can do it, and therefore they can go home. But perhaps they're not cognitively where they used to be able to perform in their highly functional capacity requiring job before. But they're returning home. They have to provide for their families. They don't get disability the same way. And then they have that burden of caregiving responsibilities that then piles on and then makes you think about the patient burden, right? So this is a model proposed by Dr. Shippey talking about patient capacity and patient workload. So the higher you can think about it like a seesaw, right? Like the higher the workload of demands, your patient capacity is going to go down. And then the demand on somebody who is going directly home is higher because you have to perform at the same ability, but you don't have it anymore. So how can we empower these people to really self-manage enough through accessible integrated services and educational materials, perhaps? Is one thought of perhaps fostering their ability. But how? How do we do this? Well, perhaps blood pressure is one target. Healthy lifestyle choices. Well, healthy lifestyle choices can mean a lot of different things, but we know that quantitative modeling suggests that 80% of vascular events after stroke are preventable through medical and behavioral interventions, but whether these work or not, then is something to think about. So then when should we try to plant that seed, right? When is the right time? Is it spring or is it fall? It's fall. That's the teachable moment. When somebody is in the hospital, when they have, and there's literature on the teachable moment about being in the ICU and when people are responsive to hearing new things that may be helpful to them or particularly open. And then again, same thing about stroke survivor and caregiver dyads. How are we teaching them then to bring home the message that is most important? So we know what works is team-based care, perhaps through multidisciplinary collaborations. We talked about blood pressure telemonitoring we know has shown promise in improving control. We know that tailored infographics perhaps can improve health literacy. We know that, does it really work? How do we put it together so that we can provide equitable access? This was kind of our working question. And then thinking about telehealth, we know that observational studies show that you can have health behavior change with chronic conditions. But then again, and also that home blood pressure monitoring works in the stroke community more recently. So perhaps if we're thinking about the feedback that these people are able to get, that may help with their self-management. So with that endeavor, we did a couple of studies, first to understand, do stroke survivors have access? Do they have internet? Do they have usage amongst the stroke survivors and their informal caregivers? And the answer is yes. Based on Pew Center data, compared to the caregivers that actually had more access, acute stroke survivors, perhaps not as much. And then, of course, there are inequities in telemedicine. And we did a 3-center study. We saw that there were differences in access in terms of video versus telephone, but that everybody was able to receive that access in one form or the other. So really thinking about how we're tailoring to what technology is available. And so we did this study called Telehealth After Stroke Care. This was a pilot randomized trial, and we looked at these components of multidisciplinary care with home blood pressure telemonitoring against control. And that was usual care. And so usual care as in what they typically got. Having said that, after they completed their intervention at 3 months, we went back and gave them the home blood pressure telemonitoring with the team. And this was really focused on feasibility. So feasibility of recruitment, feasibility of randomization, and then adherence to the video visits. And that worked out fairly well, but we also saw that systolic blood pressure seemed to be well improved amongst the intervention group versus the control group. Now, why was that the case? And yes, it's a small sample. And so again, just walking through the study itself, we used these infographics, but this was right at the beginning of the study. So at the instant where somebody has just gone from the hospital and is at home, describing to them why blood pressure is important. I think I overloaded the system. Well, a good breather, I guess. Oh, okay.
You just cycle all the way through.
Oh, this is gonna do.
Oh, because you've got to go through each one. Yeah, let me do it. Why didn't you tell us what
There you go.
infographics are? You were
Halfway through.
halfway coming up here, right?
There
No?
you go. Yep, that
That's
is.
a good place to start.
Okay,
Can you tell us what
So-
infographics are?
so just looking, okay, hopefully it'll stay. This was an infographic, which is an informational graphic that displays patient information perhaps, or just educational material. But this was designed through a community participatory design. So it was an iterative process designed with the local community on even just placement of where these things are placed on the screen for them to understand visually what we're talking about. So it's that whole idea of using a picture to explain 1,000 words. And so what this one is about, it shows you your own data. So that location where there's a blood pressure reading, that's the tailored information. So we provided them with, this is where your blood pressure was when you were discharged. This is what's normal on that grid, and this is where you landed. So it, again, for lack of a better word, contextualizes where someone lies on a range. So it helps someone see themselves in the picture. And that's one place to start that education. But then that needs to be followed through. So again, there, right, I think we,
Just go to slideshow now. Let's do slideshow. Hold on.
see, this is called transitions of care problems.
Transitions of slides problem.
Stuff just flows through. Anyway, I'll keep talking. What we found was that patients who were adherent to blood pressure monitoring and had been doing it for a while, they just continued in the program, and we found them super adherent at the end of it. And that really made me think about, why is this actually working? Are we thinking about what it's doing for patients at the individual level, which then led to qualitative work. Because what we got back in terms of patient-reported outcomes was perhaps not enough, but was indicative that there's something underlying that. And so I wanted to share the PHQ-9 data from that. And we looked at depression scores, and we found that in the intervention group, they seemed to do better in terms of their depression scores. So again, this is small amount of data, but it suggested perhaps that there is a role for how we may be improving their mental health through the social support that they're getting, which then goes into behavior change and how we're thinking about social support. And perhaps being able to do that in a way that improves self-management. Perhaps it's a counterintuitive thought process, like how are we improving support by providing support for self-management? Well, you just need a helping hand right after you've had a stroke. How do you do that in a way that's not pervasive, that you are not injecting yourself in the person's life, but are able to are enabling them to flourish?
Carry on.
And so part of that was qualitative work, where we went back and talked to those participants to get a sense of what it was that led to their behavior change and whether there was behavior change or not. Now, thinking about qualitative work, I had never done that before. I mean, you ask me to run correlations and regression and whatnot, and I can do that. But this is different. You have to think about, what is the behavioral change model, perhaps, that you want to think about, that you want to use. And there are so many. So there's a wonderful book by Karen Glantz at University of Pennsylvania on human behavior change. And there's many different models. It depends on which one you, maybe we'll just
Just use it now.
Just use
Don't
it.
try the slide view.
Yeah, just go with that.
Okay. So again, this was the one I wanted to show for the PHQ 9 scores, and we found, and these are individual circles that represent individual patients and their change that was clinically relevant. So a difference of 5 is relevant clinically on the PHQ. And then I think I'll just sit down and change it. So same thing with PROs. We found again that it was significant looking at task versus control. Again, the intervals were wide, it's a small sample. But then thinking about why it's helpful, do we need stakeholder perspectives to understand what the underlying target is? Why is there a good adherence or lack thereof? We know that recruitment and retention in minoritized populations takes more person power. You have to reach out more. So if there is that intensity, then how are we improving upon that? Of the different theoretical frameworks, the reason we chose social cognitive theory to anchor our qualitative work on, which you can or cannot do for qualitative work. You can start off with a inductive type of content analysis where you just look at what people are saying and you come up with themes and then decide what are the most important ones, or you can go a deductive route. We decide to go with deductive and use social cognitive theory with the idea that clearly there's something about the feedback that people are receiving from their environment and how that's changing their behaviors through their cognitive load. And for that reason, the social cognitive theory applies really well, because it is that triangulation between the cognitive piece and the behavior with the environment and the feedback from each of these. And then, so we did physical activity monitoring for these individuals based off of the feedback that perhaps physical activity is an important aspect to how these mildly disabled individuals are doing in terms of their recovery. This was our patient characteristics, 50% female, 57% non-Hispanic Black, and non-Hispanic white was 14%, Hispanic was 29%. And we also did, of course, some patient-reported outcomes. So that included the IPAC, which is the physical activity questionnaire, and then the PROMIS physical function score. The Eureka stage score gives you a sense of where am I in terms of behavior change? Have I even started thinking about it? Do I even believe in it? Am I prepared for it? And then we looked at daily step counts for individuals. These were about 5,500 for the mildly disabled stroke patients, which is actually average in the
No,
US.
can you just click on the slide? Yeah, click on the slides that you're talking about. Yeah, thanks.
And so this was the timed up and go study that we did at these mildly disabled chronic stroke survivors. And we found that, the fall cutoff is 12. And that 62% of these people were above this. So they were living in the community with this risk of falling and had truly not integrated back even after a year. We looked at their tug time versus their average daily steps, and we found a moderate negative correlation, meaning in terms of what they can do versus what they're doing, there is a discrepancy. This QR code is a video of how to do the video timed up and go test. It is perhaps a better indicator of how somebody is reintegrated in the community, whether they are able to walk like or be balanced enough like anyone else or not. And it's perhaps a little bit more sensitive than the NIH stroke scale, although we didn't do a head-to-head comparison, because these are people who may be a 0 on the NIH stroke scale, meaning they don't have a drift, they're talking okay, but perhaps you are not picking up the exam. And this may be helpful. So these are the infographics that we then went ahead and tailored in terms of their physical activity report. And we went through it with each individual, with their individual data, which ended up being slightly different for different individuals. And so being able to find a one-size-fits-all is perhaps somewhat difficult. And this goes through, how many hours were they sleeping, how many average steps they did per week, were they really achieving their moderate to vigorous physical activity, and then the total amount that they were spending per week. And this was just the data report. And then we realized people don't know what moderate to vigorous physical activity is. None of them were able to tell us. We had a participant who's a housekeeper, and she thought she was in the pre-contemplation score on the Eureka, and she thought she was not doing any physical activity, and she was killing it, 10,000 steps a day. She was working. And so again, comes back to how you contextualize what you're actually doing and where you need to be. And so we created these infographics in English and Spanish with the participants on what is moderate to vigorous physical activity, how can you visualize that, how can you break this down, and then how do you motivate yourself to come up with small steps that you can do to get you closer to that goal. And me to the next slide. So this is a slide again. This is supposed to have the circles come up at different times, but I will try not to play with that. This is basically all these quotes and how people are talking about it, and then putting it together into where it adds up on so just as examples, so expectations, right? What are expectations? They're based off of prior experiences. They're based off of what your knowledge and your skill set is. So something like, I'm a active type. I want to participate. That's why I go to this senior center, because I socialize. I have an expectation that I will enjoy that activity, which is why I'm doing it. I don't want to have another stroke. And then the fact that I could check my blood pressure, see the results every day, to me, that was helpful. I never want to stop doing anything. I know it's tough, but I'm going to do it. That's the self-efficacy piece. And then it's about the agency that comes with, I knew somebody was looking out for me, taking ownership of my numbers. That was helpful for me to test it. So that feeling of, yes, I can do this, that blends into agency that makes you feel more confident. Because I want to do this. And so how are these numbers playing a role?
Imama, could I just go back to that slide? So that slide is showing those words, terminology in the circles. That's social cognitive theory model. That's you're fitting the comments into that model.
Yes, so exactly this. So the social cognitive theory basically talks about what are behavioral factors, what are cognitive factors, what are environmental factors. How do you distill that out into understanding where people are coming from? How I would distill that out based on the social cognitive theory is that these cognitive factors are driven by positive outcome expectations. You know that this is going to be fun, therefore it's easier to do every time, but that blends in with the behavioral factors of actually doing it, and therefore the environmental factors that come with the actual process of doing it, which is then the agency. Sorry, the slide is coming up really small. These are kind of the key things. Assessing prior experiences. So when we think about designing interventions, are we assessing their prior experiences? Are we getting a sense of where they're coming from in terms of their experiences? Maybe the blood pressure cuff was too tight, so they stopped monitoring like years ago, and now their blood pressure is super high and they don't even know it. Educating them, what kind of cuff do you need? What time do you need it? Same thing for physical activity. What is physical activity? Practicing that behavior. So doing it enough times that it becomes a skill that you don't have to think about. But to start that off with the environmental factors of that support that you're able to initiate, perhaps earlier when they have a teachable moment and they're open to learning new skills. And then monitoring to see that they're able to do it so that the engagement continues. It's like riding a bike when you're little, and then you have somebody to help you along till you just keep doing it and you don't think about it anymore. But breaking that down into small pieces that we're putting in these behavioral interventions that helps continue these behaviors with that adherence that we're looking for. Again, these are the key individual factors. So there's a gap between the knowledge and participation in these behaviors, and why we don't have these systems in place, because it starts at that individual level. How do you get them? How do you get people, including myself, to be more engaged? It starts at the individual level. So these factors, including the outcome expectations, self-efficacy, and agency, specifically in the minoritized populations where we have the most need, requires tailored education, where we need that iterative design, where we have community members who tell us what's working when they're looking at something, what's not working, providing them the support at the bedside where they need it, with the family caregiver who's able to be linked in, and monitoring so that they don't feel like you've abandoned them. So this is a behavioral mechanism model that we created based on the qualitative feedback that we receive from individuals with the framework of the social cognitive theory. Therefore, agency is that cognitive aspect of perhaps where you are increasing attention allocation to something because it's fun to do, you keep doing it. And then you continue to reframe your expectations based on that positive outcome to the point that it becomes automatic. Because you are getting direct motivational feedback and then you are receiving feedback for yourself and through that support network. So it's almost like it's a halo around getting your cognitive load decreased enough that it becomes effortless.
So can I ask a question here, like, so if you're talking to someone and you perceive that their agency, cognitive agency is low, do you know how to intervene to change that? Like, are all of these linked then to specific inputs that you would change to move them on this continuum of behavior change?
Exactly. So it's because they're all so tied together, it is important to have each of these aspects be part of what somebody's receiving. Perhaps some individuals need less of it. So perhaps if somebody is, and I'll share this with the next study that we did, perhaps the amount of time someone needs is different for different individuals. So in the past study, we had patients who were adherent in the first month and continued to be adherent out of 3 months. There were people who were just adherent for the first month, but then continued to take their blood pressures using their own devices. And so we do have to, like, the short answer is each of them together work best. So it's not one that you can distill from the other. And that, I think, is the piece to why behavioral interventions fail, perhaps, is because all of these components are not part of what somebody's getting. But that tailored intervention needs to include tailored education at the patient's level. So for somebody who already knows what step counts are, perhaps it's about understanding what step count is going to get me to moderate to vigorous physical activity versus not. And how do I understand my numbers so they're simple enough, but complicated enough for me to engage with the text. And so that's the nuanced approach that we had with the iterative design of the physical activity data report to keep it simple but not too
Would
simple.
that middle piece be called habit formation? Is that what's?
This
I mean,
is
it's the
all
science
part of-
habit formation.
This is all science of habit formation. And then extending that, so there's this debate about habit formation and multiple habit formation. So can you stack up? So that's sort of exactly extending that. Can you have multiple habits that you can stack on top of the other, and that will lead for better lifestyle modification? So it's not just one thing, but multiple things. So perhaps if we are thinking about, I take my pills in the morning. And so this is what these individuals reported. I take my pills in the morning and then I take my blood pressure. So that's not one of the quotes here, but it's habit stacking so that they have less cognitive load to remember. But then being able to guide along that habit formation is how we have to tailor it to each individual because their barriers to that habit formation can be different. What we did find that was kind of unifying was more than 2/3 of our patient population, and these are the mildly disabled chronic stroke survivors, said soon after the stroke, they had this fear of falling. And in particular, one said my biggest fear was falling, and that was the only thing I was concerned about. And this is kind of like a verbal heat map that shows fear of falling was tied in with their physical environment and also their outcome expectancy. So they thought, if we walk a lot, we're gonna fall. But perhaps that was not the case, which is literally why they were discharged home, because they were safe to go home. And that's where the difference is. So we came up with this study where we did some pre-intervention work, going back to mildly disabled chronic stroke survivors and asking them, what do you think of this? Yes, you said fear of falling is a concern. How do you think an intervention where perhaps somebody comes to your home and goes through exposure therapy, guided principles, using task-specific training, which means the physical therapist works on what you're most afraid of with the idea that you're doing cognitive restructuring every time you're exposed to that specific task. And so that is what we came up with, and it ended up being this amazing transdisciplinary care model that we've come up with, because there's a psychologist who teaches these principles to the community health worker. It's manualized, and then there's a physical therapist who teaches the primary principles of physical therapy to this community health worker. And the plans are tailored to the patient. So if the patient is most afraid of taking the stairs, that's the first goal. Each patient is taught how to stand from if they were to fall. So that fall to stand is part of their ability to, yes, if I fall, I know how to stand up. Using the pre-intervention group was something that I thought might be helpful to understand how patients would perceive this intervention. I was actually amazed by how informative it was and how quickly these stroke survivors understood what we were saying because they were living it. And for these patients who are mildly disabled, they said, this needs to be extended to people who can still, walk, but not so much. And so we ended up changing the MRS to 2 or more. I also analyzed this based on the social cognitive theory principles in terms of what the qualitative feedback was. And they all said that the data monitoring would be helpful to continue the feedback loop. And so we integrated Fitbit monitoring for 3 months for these individuals. We knew that it was feasible for a month. So far, it's going okay for 3 months. This is just the patients enrolled so far. We do have an eligibility criteria. So we are really thinking about the behavioral mechanism at play, which is so important to designing behavior interventions. Because if you think about it, for a drug, you have a mechanism. You know that this drug will work because it's going to go to this receptor and then it will get internalized and it will have this effect. And that is so quintessential to any intervention design from stage 1 up to stage 5, because you come back to that. So what are we doing? And then you have to titrate dose response. And so it's a cleaner pathway. But when you think about behavior interventions, perhaps thinking about the underlying mechanism that might be at play that you're able to alter is important. Here we think that it is avoidance behaviors. So I avoid walking because I may fall. And so how do you unpack that? My avoidance behavior is because I do not have control over whether I will fall or not. Therefore, I will do what I can, which is not walk. That's going to be bad for me. So ABC is an activity-specific balance confidence scale. It's well validated for stroke patients. And so we're using that as an eligibility criteria. So a cutoff of less than 80 tells us if somebody's confident in being able to have balance or where they are in terms of their fear of falling. So we're using that as our sort of benchmark for enrollment in the study. And then I think.
Yeah, we need like five minutes for questions, Imama, so if you want to.
I think that was the last slide.
Maybe tell us.
But I did want to have the acknowledgement slide there, I guess.
I'm trying to get your now.
Okay. Well, so food for thought, primary prevention, risk reduction, cart before the horse. What does that mean? What about people who are caregivers to these stroke patients living with stroke and dementia? What does brain health look like for these individuals? The recent guidelines, coming back to primary prevention, says healthy lifestyle behaviors, use Mediterranean diet, think about social determinants where somebody is living, trying to mitigate that, puts all that onus on the providers, which is perfectly okay. But then how do you do that in a way that's sustainable? Again, trying to do that before all of this bad stuff happens would be wonderful. Way forward, patient-oriented outcomes, yes, because they're patient-centric, they may not be perfect, but that is what we have for now. And perhaps for behavioral mechanistic targets, that is how you get at it. And they're still under development for a lot of different reasons. There is the SOBC is a website that you can access. It has different behavioral mechanistic surveys and it goes through different targets as well. So maybe worth looking into interdisciplinary care best practices, local populations, really tailoring it to the resources at hand, and then incentivizing policy change for implementation long term. These are my acknowledgements for my mentors and then for my team.
Thank you.